So it is Wednesday, the 30th of June. It is almost July, folks. Tomorrow is July. Think of it that way. Then we are only a few more months closer to Christmas. It is Wednesday. It is hump day. Hump day. We'll soon be through this. And yay, Christmas, right? And then you guys will have a nice long weekend. So today we're going to talk about cervical and thoracic spine. Specifically from the standpoint of kinesiology and talking about reviewing the anatomy stuff and stuff like that. Like I said, cervical and thoracic spine, Dr. Reskin will cover in depth next semester in Therex. And also with her classes where she actually gives you some of the new training she's doing on cervical and thoracic spine as well as lumbar spine. So we'll talk about it. And hopefully by the time you get to her class, you're a little bit better prepared. So it's really hard to separate out the motions of the spine because the motions of the spine all go together, right? Even though we're doing flexion of the neck, even though we do that and it's primarily motion of the neck, there's still some motion that's occurring further down in the thoracic spine. You can even technically feel a little bit of it occurring down at the lumbar spine when you move stuff around, right? When you bend over at the waist and get lumbar flexion, you tend to actually have some cervical flexion that goes along with it. So we typically have flexion, which is forward, and then we have extension, which is return to neutral. And then we have hyperextension, which is where we go past neutral and kind of look up. So at the cervical spine, right, we have flexion, we have extension, turn neutral, and then we have hyperextension, looking up. That's cervical flexion. There also is this thing called capital flexion and capital extension. And when you hear capital, remember what I said, we talked about the capitate and the capitulum. Capital means what?
Your head.
Head, yeah, right? So there is a little bit, if you can isolate your neck, of capital and capital extension and flexion that goes on as well. Now, most of the stuff that occurs towards up to your head is more of the rotational component, right? But there is a little bit of capital extension and flexion, and a lot of that occurs when we do stuff like that with the neck, where we protrude or retract the neck. We also have lateral bending, side bending, right? Putting the ears to the shoulders. Our trunk also has lateral bending. Oh, that actually felt good. We have rotation of the neck. We have rotation of the trunk, right? And then, like I said, we do have some axial, or this axial extension is also known as capital extension. And there's also a little bit of capital flexion. And again, it depends upon the muscles that are activated for it. So let's talk about some bony landmarks. Well, the main bones we're going to talk about when we talk about any type of motion of the cervical region, right, are the vertebrae that make up the cervical region, and then the occiput, because the occiput does a lot of our connections with the muscles and everything like that. Now, the mastoid process of the temporal bone also is there as well, but for the most part, it's a lot of our occiput, right? So we have back here. On the occiput, obviously, we have the occipital protuberance, right? That's the big bump back there. There is this area called the nuchal line. Did Dr. Johnson talk about the nuchal line with you guys in anatomy?
Not really. We just went over the structure.
Okay, went over structure. That's whatever. Right. We're going to talk about that a little bit when we get to the nuchal ligament, or the ligamentum nuchae. What the nuchal line is just an area where the nuchal ligament attaches onto. That's why it's there, right? We know that most of our most of our lines are there to attach ligaments or muscles. That's kind of what the nuchal line's job is. The basilar area of the occipital bone is down under that foramen magnum. Why do you think this is called the basilar area of the occipital bone? What do you think?
The base?
Yeah, it's the base, good, right? And what sits right above it? What structure do you think of the brain?
The cerebellum?
Right. Cerebellum, right? And part of the basal ganglia. the base, right? The basilar area, that's kind of the area of that brain, right? It's the base of the brain too. We have our big old foramen magnum, and there are lots of problems that can occur with this foramen magnum. There's actually a condition where the actual base of the brain can extrude below the foramen magnum. And you get part of the brain kind of sticking out the base of your foramen magnum. Does anyone know what that's called? You may have talked about it in pathology. It's called an Arnold-Chiari malformation. Happens a lot with kids with stuff like hydrocephalus or maybe even Downs, where the base part of the brain, so the brainstem itself, extends out a little bit past your foramen magnum. Could that be problematic? Absolutely. Right? The reason your brain stays in your brain or in your skull is because of protection. If you stick part of it out through that hole, every time you kind of turn or move your head, you're putting extra compression on that brainstem. That can cause problems. Then we have our occipital condyles over there, right? Our occipital condyles are what help us articulate with the spine itself. And then at the temporal bone, the other thing we have is the mastoid process. Why is that important for the neck?
It's an attachment for the sternocleidomastoid.
Exactly. That's the main part. It's the attachment for the sternocleidomastoid, which is actually a really, really large muscle of the neck, right? It's one of the big movers of the neck. That's why we're doing an anatomy review here. It's loads of fun, right? So then we start going down and looking at the actual two first vertebrae, right? So we have our two first vertebrae, right? C1 and C2, the atlas and the axis, right? And which is C1? Is the atlas C1 or is the axis C1? Okay. Why? How do you remember that? Is there any way, did Dr. Johnson teach you any way to remember that?
Axis has the dens.
Okay, good. That's one way. T becomes 4x. Okay, good. That's one way. Yeah, that's the way I remember it, Mara, is the globe, right? Axis is the guy that holds up the globe, right? Atlas, right? And so C1 is the atlas because it's holding up your head. And the other thing is the axis has the dens, like I believe Brooks said, which is where rotation will occur, right? We'll rotate around that. And when you have an axis, you're rotating, right? So we have on the atlas up here, we have our articular processes for those condyles of the occiput, right? We have that dens that pops up through that little articular arch here, right? We have a bunch of ligaments that go along. We'll talk about those later. We have our transverse foramen. We have our posterior and anterior arches, and then we have our spinal canal or the vertebral foramen, right? What always amazed me is when I went down to, so that's C1. When I go down to C2, the cervical foramen gets a little bit pinched in there to me. It looks a little bit smaller than it is up here. Well, that makes sense because the column's going to get a little smaller as it goes down. It gets more tighter packed. On the C2, the main thing you need to know is about the dens, right? It's that big protrusion up there. Then we have our facets, and we're going to start having our transverse processes with our transverse foramen again. And our lamina are going to start happening here, right? And our spinous processes. So the lamina go out to build our spinous processes in the back of the neck. This dens here is really important because it kind of keeps the head from rolling into the spine when we do flexion and extension, right? That's part of its problem. It's to keep it from, when we get this kind of larger area up here where we have a larger portion of the spinal cord, it kind of keeps us from compressing it down too much. Because again, we know any compression in the spinal cord causes problems somewhere. So then as we go down, right, those spinous processes start getting a little bit bigger and bigger until we get down to C7, where we have that really big kind of spinous process, right? processes. And then once we get down and we start moving down into the thoracic vertebrae, the spinous processes get a little bit more kind of straight out, but the bodies get bigger, right? So you get the thoracic vertebrae start getting bigger and bigger and bigger until we get down to the lumbar region where the bodies are very large. Well, that's because we're going to start weight bearing through that region, right? The cervical vertebrae only have to carry the weight of the head, which is 8 to 12 pounds, depending upon what source you read and stuff like that, and how big your head is. Once you go so far down the cervical region, though, you're going to start adding some additional connections, right? You're going to add these facets for the costal region, which is where those ribs will attach into, right? So the main thing about the actual vertebrae of the spine is they're pretty much in constant change as you go down the spine, right? They're going to get bigger in some areas. Some parts are going to get smaller. We're going to add parts. We're going to take away parts. But it's kind of amazing when you think about the way we've kind of developed for this. Because in reality, this all develops in utero, right? Does anyone know what the spinal cord is called before it becomes the spinal cord when it's in utero? When you're basically just a giant tadpole in mommy's belly. The spinal cord itself is called the neural tube. The neural tube will eventually cordon off and become bony encased. And when it becomes bony encased, that's when it becomes a spinal cord. There are a lot of studies, and we can get into, I'm not going to try to get into the debate here about abortion or anything like that. But there are a lot of studies that are saying that until that neural tube is fully closed, really, we don't have a human. We have essentially a tadpole. Right? Because when that neural tube is not closed, most of the time it does not support life. So if, you know, for whatever reason, before you were born before the neural tube closed, which can't really happen, even if the fetal heart is starting to develop, it doesn't matter because without that neural tube being fully closed off and protected, there's not going to support life, right? Outside of the womb, that embryo is not going to survive. So again, I'm not going to get into the arguments about that, but just kind of a thought process there when we're looking at it, right? We've got to realize at some point, we've got to look at when is life viable. So we get down to our vertebrae and we got a bunch of different parts, right? We have our body, which is our main part of our vertebrae. That is our weight-bearing surface. In between each body of vertebrae, we have our intervertebral discs. And what's their job?
Shock absorption.
Shock absorption. So Brooke says when it's fully cut off. What do you mean by fully cut off there, Brooke? I'm sorry.
I was asking when it was, because you were saying that.
So it depends upon the books you read. And I want to say that fully neural tube development doesn't close off or harden, basically. They call it closing off is when it hardens off.
Oh.
Right, until probably late second trimester or early second trimester. So it's a ways into the baby being developed, right? That's not 5 weeks. So I'm not going to, like I said, I don't want to get into the debate about the whole abortion thing because I have my opinions. Everyone else has their opinions, right? That's kind of why we all have opinions.
Oh, yeah. I was just curious on like just the spine itself and the.
Yeah, so the spine itself will continue to develop. So once the neural tube closes off, once that vertebral arch is formed basically around it, then the spinal cord will start lengthening. And that's what makes baby big, right? So it causes baby to grow. And then eventually the cauda equina will develop, and then the legs will start growing, and then arms will start growing because suddenly we get brachial plexus, right? It's all kind of cool the way the baby actually develops. And hopefully, because I know we didn't do the trip to bodies with you guys, did we?
Mm-mm.
Yeah, so hopefully we can do that. Maybe once we're back to full campus, we can take a class trip down to bodies because they do actually have in the bodies exhibit down at the Luxor, a room that's kind of controversial. It's kind of hard for some people to go into, where they actually show what fetal development looks like through the weeks and from the cluster of cells it starts at until you have baby, which to me is amazing. Like the way that human life develops is amazing. Actually, any life develops really. It would be awesome, right, Truman? So maybe let's see. Usually we can get a pretty good discount. The last time we did it was like $12 or $14, and it's normally like 40 to get in. So we'll see. Maybe they'll make some more deals because they just need people to go in. I will actually let me write that down before I forget about it. Because I always like to invite Dr. Johnson to that because he's a good wealth of information while we're doing it. Again, so we have those bodies. Then we have the neural arch, right? The neural arch is where what's going to pass?
Nerve.
Right in front of it. So right here's our neural arch, which is kind of the back side of it. In front of it is where our spinal cord is going to pass. It's forming the arch for the spinal cord. That forms our vertebral foramen. Then we have our pedicles, and pedicle means foot. So the way I look at it is at the sides of the body, we have feet. Those are our pedicles. So once we get past the pedicles out there, we end up out here and we form the wings of the vertebrae. And the wings are the transverse processes. Those are what you can really palpate when you get on the spine, right? You can find the spinous processes. And if you kind of go lateral to the spinous process, you can find those two wings of the transverse process that you can actually move around a little bit. Can't really move around the pedicle because it sits in front of the transverse process. And then from the transverse process, we then go back into the lamina, right? The lamina then lead up to build the spinous processes. And that's the way your vertebrae is built. Now, there are other parts of it, obviously, right? Because we have our superior and inferior articular process where those vertebrae interact with each other. And then in some of them, like I said, we're going to have the costal facets where the ribs articulate as well, which is not shown on any of these things, right? But every vertebrae above is going to articulate with the vertebrae above and the vertebrae below. So you're going to have a superior and inferior articular facet. The only time you won't really have an inferior facet is when you get down to like S5. But at that point, you're... Oh, no, actually S5 does have one because that has the coccyx that articulates with it. Maybe the tip of the coccyx doesn't have one. So whenever you hear of somebody having surgery and heard of them having, has any of you heard of somebody having a laminectomy before?
No.
So a laminectomy, so right in here, we have spinal nerves kind of passing out. If this lamina, and we get some kind of osteoarthritis building up there, starts pressing on those nerves, what they can do is called a laminectomy. What they do is they go in and they open up that lamina and they'll cut it open. Laminectomy, cutting out of the lamina. And that opens what's called the neural window and allows for more space for that nerve to pass out. Sometimes what they do is they totally remove this whole posterior arch. That's what, if you actually get to feel my neck, I don't have spinal processes from about C4, C5, C6, I think is where I'm at, where they remove that whole window and they just basically put extra those screws and plates in to hold my spine together to allow for more space. It is a very common surgery of the spinal cord and the vertebral column. Absolutely. Laminectomy is probably the most common. Posterior disc fusions, anterior disc fusions are probably the second most common. And we'll talk about ablation surgeries and stuff like that when we get to pathologies here coming up. That's the basic buildup of the vertebrae, right? And then we have our facets, where those facets kind of articulate. We have our costal facets, we have our superior and our inferior costal facets, right? That articulate on our vertebral bodies, allowing those ribs to articulate with us. We have intervertebral articulations where things move together. And then we have our intervertebral discs, right? And those are important because, again, we said they absorb shock, but they've got the donut and then they've got the jelly, right? The donut is our annulus fibrosus, and then our jelly is our nucleus pulposus. In a perfect disc, it would open the spinal cord for more issues, John. Good question about the spinal surgery. But the problem is in the case, like we're going to use mine as an example, And I have to get a CD-ROM drive so I can get my, so if I can get I found my MRI where you can see the compression, the amount of compression that was on my nerves going out to my arm because of the collapse of my lamina. It was better to cut them out and put a plate in there and give space for them so they could actually breathe and actually send the signals. So yeah, it could, right? And the other thing is, you'll find that once you start a spinal surgery route, it kind of causes a cascade. And we'll talk about that with pathology coming up here, that once you have one spinal surgery, guess what usually happens? You're going to have a couple more down the road. But back here to the discs, right? We're going to talk about what happens when the jelly escapes the donut. Because when the jelly escapes the donut, we got some problems going on. The ligaments, there are a ton of ligaments on the spine. It makes sense because the spine is what holds us upright. The strongest of those ligaments is the anterior longitudinal ligament. It is strong bad. The anterior longitudinal ligament, anterior meaning front, longitudinal meaning running the whole length, is a ligament that runs all the way from the top of the spine all the way down on the anterior surface of the spine. Why do you think that would be important for that ligament to be super strong? Anyone have any ideas? Yeah, protect our internal organs. Exactly, Anthony, right? It keeps these vertebral bodies and everything from shifting forward, right? Which is why you're going to see it's pretty rare, right? If this is our vertebral disc, right? We have vertebral discs that shift laterally, they shift posteriorly when we have problems with herniations, but it's pretty rare for those vertebral discs to shift anteriorly. And why is that? Well, it's because of this anterior longitudinal ligament. It's not going to let that disc kind of slide up against it. It's just going to push it right back into its spot. Does it happen? Sure, it happens, but it's a pretty rare occurrence that we get an anterior slip of the disc. If we have an anterior longitudinal ligament, then we also have our posterior longitudinal ligament, which runs around the back side of the bodies. We also have our interspinal ligament. That is going to go between the spines, interspinous process ligament, right? We have our supra, above or on top of spinal ligament that runs on top of the spinous ligaments, right? We also have this thing called the ligamentum flavum here, which kind of runs on the inside of that vertebral canal. There's our posterior, right? It runs kind of right in there, and it helps kind of connect those vertebral canal parts together. And then we have the nuchal ligament, right? The nuchal ligament itself starts up at the top at your nuchal line and holds it back there, and then eventually becomes the supraspinal ligaments in the thoracic spine. So up in the cervical spine, you really don't have a supraspinal ligament laying over the top of your spinous processes. That's just your nuchal ligament, which eventually goes down and starts forming that supraspinal ligament from thoracic spine down. I just like calling the ligamentum nuchae because it sounds fancy, doesn't it? I am talking about the ligamentum nuchae today. Oh, that's interesting. I didn't do that on purpose. That's cool. I don't remember doing that. There's a pretty picture of the nuchal ligament. I don't know how I did that. That's sad. That's what you get when you're tired. So muscles of the neck, specifically of the cervical spine to start with here. On the anterior surface, so up here, right? We have our sternocleidomastoid, which is our big daddy, right? There's our big daddy muscle. What does the sternocleidomastoid do again?
Cervical flexion and lateral rotation.
Good, okay. So now I'm gonna add the trick question here. So it does flexes and rotates. Which way?
To the opposite side.
Okay, which is the opposite side?
Like,
So flexion occurs to the same side or to the opposite side?
Same side.
Same side, right? Flexes same, rotates opposite. It's this motion here. Right, so when I do that, right, I'm kind of tightening up this SCM over here.
did I say opposite?
I don't remember what you said at this point. Don't worry, Brooke. It's, if you did, I have no idea. I'm just going to say you did it right and just accept it. How's that sound?
Okay, I forgot what I said.
That's okay. I do too. So I have the attention span of a gnat right now. So when I turn opposite and flex to the same side, I'm working that one side. So in this case, I'm turning left, laterally bending to the right. So which muscle is tightening up? My right or my left SCM? Good, my right. Exactly, Anthony. And that's going to come into play when we talk about something like torticollis. The other muscles we have are scalenes, right? Now our scalenes are a lot smaller. We have our posterior, we have our middle, and we have our anterior scalene. That anterior and middle scalene form that scalene triangle where that brachial plexus dives out. We also have this group called the prevertebral group. Now, the prevertebral group all have their own names, okay? I'm not going to be mean and require you to know all their names because I can't tell you like I'm not really good at identifying rectus capitis anterior versus rectus capitis lateralis versus longus colli, stuff like that. So these are the prevertebral group. They're the part that are in the front of the vertebrae that are going to allow, if they're up there in the front, what motion do you think they're going to cause? If they contract, flexion. Yeah, right, they're going to cause this. There's one other muscle that's not on this list, but that muscle lays over the prevertebral group, kind of like this. It also lays over the anterior surface of the scalenes and the sternocleidomastoid. Does anyone know what that muscle is that kind of here that helps tighten up the neck fascia?
Platysma, I think.
Platysma, good, right? Starts with the P, the platysma. It's one of my favorite muscles. It's also the muscle of shaving, right? Because when you tighten your neck up so you can shave out the neck, which I've really got to do, it's the platysma, right? The levators in the back. We're going to talk about that in a second, actually. That's okay, Diana. So those are kind of our primary flexors. Then we have our extensors in the back, right? We have our rector spinae, right? Our splenus capitis and splenus cervicus, right? Capitis going to head, cervicus going to the cervical vertebrae, right? And we also have this thing called the suboccipital triangle or the suboccipital group formed by obliquus capitis superior, rectus capitis posterior minor, obliquus capitis inferior, and we also have this rectus capitis posterior major, which is in there as well, but we don't talk about that one as much. But this triangle here causes a lot of problems for people, especially when you get stressed. Because when you get stressed, you can just feel that tension developing right back there on those occipital protuberances, right? And you're like, oh God, I'm just tightening up. Oh. And probably if you go back there and you take your thumbs, you find kind of those lateral aspects of the occipital bone and kind of push in there and massage a little bit. All of you are probably going to go, oh my God, that is really tight, right? That's at a suboccipital triangle. Shin tucks will help with those, right? That's why we do that. Did I freeze? Am I still working?
You're still working.
Yeah.
Okay. Anthony just froze. That's all. That's okay, Anthony. I just freeze tagged you. I was really concerned. I was going to hold. No, just kidding. So that suboccipital triangle, we're going to do a very specific technique on. Does anyone know what technique we're going to do on that suboccipital triangle to help release it?
Traction.
Traction a little bit, and then suboccipital release. Good, yeah, right? So we're going to get in there and get our fingers on it and kind of cause it to relax. We're actually going to practice that during lab. And some of you will love that and be like, oh my God, this is heaven. Just stay there forever. Right? Anthony will be like practicing it on Truman, and Truman's like, I love you, Anthony. Just keep doing that. And then some of you will hate it, because some of you, when we get kind of tight on that, you're gonna be like, oh my God, I didn't realize they were that tender and that really hurts. A bromance is gonna go on exactly. But yeah, those muscles are, so when we do chin tucks, we're kind of tightening those muscles up and like causing them to stretch out a little bit. It does help with that, but it still tightens up. I have 3 monitors and can't find my cursor. It's great. So then we move down kind of the trunk, right? And in the trunk on the anterior surface, the main muscles we have is rectus, darniarchildus, abdominis. We have our externals and our internal obliques, and then we have our transversus abdominis. All of those come into play when we are working on it, right? So we have our internal obliques kind of going like this, our external obliques kind of going like that. The main one we're going to talk about when we talk about low back problems and back pain is this one here, the transversus abdominis. We can have a super strong rectus abdominis, and we still have back pain because this transversus abdominis isn't strong enough to hold the girdle of your belly in. I bullied Anthony out of here, I know. He's probably on Cox and getting kicked. Right? That transversus abdominis goes across the girdle of our body, and that's what holds our belly in. That's what also, if you can tighten it, when we did those abdominal squeezes, right? Abdominal bracing, you can feel it tighten up your low back as well, because it pulls on that thoracolumbar dorsal fascia. And it holds your back nice and tight as well. Interesting fact, if the patient has a really tight thoracolumbar dorsal fascia, sometimes they'll be limited in shoulder flexion. Why?
Because it's pulling them down.
Is it what?
Is it because like it's pulling the lat down a little bit?
There you go, the lat. Yeah, right. We don't think about that a lot. But sometimes if you have a tight low back, because it's so tight, your lats can't extend anywhere, and you end up limited in shoulder flexion, which is kind of wild when you think about that. Something happening down in your low back actually can affect your shoulder flexion. But the big muscle we got to get those patients that have back pain working is that kind of that transverse abdominis. Now, it doesn't hurt to strengthen our internal and external obliques and our rectus abdominis as well, but you can have really, really super strong rectus abdominis and still have low back pain. And on posterior surface, when we get back to the back, we have our rector spinae group again, right? Our longissimus, our costolis, our spinalis, all those fun ones that go along with the rector spinae. We also have what's called our multifidi, or our transversospinalis muscles. Just call them multifidi. The multifidi are going to be responsible for going transverse, going across the spine, spinalis muscles. They're going to help a little bit with rotation. They're going to help a little bit with lateral flexion, but they also connect then onto, so when that thoracodorsal fascia comes back, that's where that thoracodorsal fascia attaches. And so they tie right in to that transversus abdominis. So we're going to work those a little bit too and strengthen that back in order to help low back pain, obviously. We have our interspinalis, intertransversi muscles. And then on the midline on the inside, right, we've got that big old quadratus lumborum. Quadratus lumborum helps us with side bending, right? Can you palpate somebody's quadratus lumborum?
Maybe if you're an LMT.
Yeah, I was going to say, pretty impressive if you can. It's pretty deep. I mean, you've got to get in. I mean, theoretically, there are techniques to get on it, but I would argue with how deep that quadratus lumborum is, again, 4 quarters, right, quadratus lumborum, that you're not really truly going to be getting on that quadratus lumborum. But I mean, there are arguments to be made that you can, and some PTs will definitely say you can. But again, when you're looking at this, right, here's our quadratus lumborum. Look at where that's kind of at in relation to the thing, and think of all the stuff we have. There's our transverse abdominis, there's our obliques, get all that kind of laying over it. If you can get down and palpate that, you're pretty good. I'm just saying. Yeah, I love when I've gone to a class where they're like, we're gonna do psoas releases, and I'm like, I think I'm gonna opt out of that because man, that hurt. Just imagine what you have to do in order to get a psoas release. That's not going to be fun. So when we talk about the cervical region and the thoracic region, the one thing we can't ignore is respiration, right? And that's the ability to breathe, because that all affects our ability to breathe. If we don't have a functional mobile thoracic cage, we can't breathe effectively. It could, John. So John asked, when you palpate the deeper muscles, that affect the superficial ones negatively. I think it causes a lot more pain in superficial ones. Like, for example, if I'm going to get in and do something on your obturator, I've got to get in and around the piriformis and a few of the other muscles. And that means I've really got to kind of dig into those muscles, and that definitely hurts. I would be surprised if like you don't you could possibly cause trigger points by doing that, but I don't have enough research to say that you can or you can't. But definitely, I mean, I would say that you could probably bruise the superficial ones with how deep sometimes you have to get. Now, on somebody that's really skinny, nothing structural, right? Just maybe a bruise here and there. Now, somebody skinny, no, I'm pretty sure I can get around most of those muscles. But you get on somebody like me that's got kind of beefy abdominal muscles, you are not getting into that quadratus lumborum. I'm just saying you ain't. Plus, I've also got, soft tissue approximation preventing it. Right? So, all right. So with the ribs, we have 7 true, we have 3 false, and we have 2 floating. Right? The 7 true are the only ones that actually articulate with both the spine and the sternum. The 3 false ones kind of come together with rib 7. And then the floating runs just kind of float out there, right? And those are a particular target when we're in the martial arts, because if we can fracture those, it usually takes the person out of the fight. We have our sternum, right, which goes right down the center, the manubrium, sternal body, and the xiphoid we already talked about. And then we also have that costal cartilage, right? That costal cartilage is what allows those ribs to attach onto the sternum. Why do we have cartilage on the front of our ribs more than bone? Well, that's to allow that rib cage to expand and contract. If that was solid bone, if our ribs, and that can happen to patients. Remember we talked about where bone forms where it shouldn't form, or things, become bone that shouldn't have been bone. These costal cartilages can ossify and become hardened where they don't allow sufficient expansion of the chest, and that can affect your breathing. Our thoracic vertebrae are important for breathing. And then obviously the mobility of those costal joints on our vertebrae, both the costal facets and the demifacets that allow everything to kind of articulate together, are really important for breathing. So during breathing, right, when we inspire and breathe in, our thorax itself is going to elevate, right? We elevate up. When we exhale and breathe out, our thorax depresses. Which one of those is an active motion? Is inspiration or exhalation a active motion? Inspiration, good, right? Breathing in, inhalation or inspiration. Because exhalation is just relaxing, right? And you'll find that a lot when we're doing, like when you did meditation and stuff like that. Most of your relaxing when you're getting in a meditation class occurs on that exhalation phase. And relax. I feel much more at zen now. So when you do quiet respiration, which is what we're all doing now, except for me, I might be doing a little bit more than quiet respiration because I'm talking at the same time. When you're just sitting there and breathing is just happening, the main muscles that are responsible for it, the number one muscle is the diaphragm, right? That's down in here. You also have the internal and external intercostals that are involved in that, and that's just mainly for expansion of the ribs, right? So when we are doing an active cycle of breathing with the patient, meaning we're actually training them on how to breathe, one of the first things we teach them is belly breathing, right? So we're going to tell them to go ahead and put their hand on their belly, right? Kind of above the belly button. And what I want you to do is when you breathe in, I want that to expand before your chest rises. Your belly should expand before your chest. This is really hard for you. We talked about this before, right? So that's the first exercise we do with them. The second phase of active cycle of breathing is what's called thoracic expansion. Now we have them put their hands on their ribs. And now when you take a breath in, I want you to focus on your ribs flaring out. So we're working on that elevation of the thorax. The third phase is coughing. We don't need to do that unless some of you have a cold, right? But that's an exercise we can work on a patient with, is that cycle 1, diaphragmatic or belly breathing, and then cycle 2, thoracic expansion, to help their breathing improve. What type of patient might we work on that with? Well, a patient that's got COVID, somebody that's got pneumonia, even somebody that's just got something like a really, really bad phlegmy cough, where they've got some buildup in their lungs. Because if we start working that active cycle of breathing, a lot of times that moves that gunk that's stuck in your lungs up to your bronchioles. And the next thing you know, yeah, COPD is another one, right? We get that gunk out and they're breathing better. COPD, we're going to specifically work on this, except instead of focusing necessarily, we will focus on the belly breathing and rib expansion. What we're going to focus on is breathing out longer than we breathe in. So I'll say, okay, so when we breathe in, we're going to breathe in for 2 seconds. We're going to breathe out for 4. So 1, 2, 1, 2, 3, 4. And the goal is to clear all that stagnant air out of the COPD lungs. Now we do have accessory muscles, right? And those accessory muscles should only fire when we are in something like a rapid breathing type scenario. What would cause rapid breathing? Running, right? Especially when you first start running, right? Your respiration picks up, and then eventually you get into kind of a phase where your breathing kind of normalizes again, unless you're me, and then you just gasp for the whole time you're running. That's cardio. But some of the accessory muscles, the SCMs and the scalenes are accessory muscles because they help elevate those ribs. Our rectus is an accessory muscle in working kind of in a reverse function where it kind of expands out and then kind of pushes in when we're exhaling. Same thing with our quadratus lumborum. It's going to help pull down on that rib cage in order to help us exhale out, right? That's why sometimes, any of you ever get where you're breathing so hard, your ribs kind of hurt down in here? Right? That's a lot of times when your quadratus lumborum and your rectus are working so hard to get that air out that you're just kind of, oh my God, I'm sore, right? Oh, that kind of hurts. So recovery position, when we breathe hard, tripod or tripod adjacent positions are their preferred positions. And what a tripod position is where you're kind of leaning forward to allow your lungs to be able to expand with gravity. So the first 3 pictures are the ones that are called your tripod or your tripod adjacent positions. When I was in football, this is the way my coach always made me recover. Put your arms behind your head and breathe out. The problem is when I'm way back here, the only thing I can really breathe with is my belly. I have no thoracic expansion able to happen because I'm all stretched out, especially if I've got a tight pec. Right? If I have a tight pec, I might be stuck here even because I can't go backwards. Is this bad? I mean, it's not bad, but it's not ideal. right? Recovering in that tripod position can actually help you recover a little bit faster. And it's funny is if you watch some of the like long distance runners, especially when you do the marathons and stuff like that, a lot of the long distance runners recover in these positions here. Mainly because at this point their chest is, so the thinking was, I'm opening my chest up. That was what the thinking was, John. I'm opening my chest up, which should help me breathe better. Yes, I guess. But the problem is now the only muscle you have for moving pretty much the air is your diaphragm, right? Because your ribs are kind of flared out. It's a lot harder to get that thoracic expansion going on. So the idea was you're opening the chest to clear the airway. And there are still several, what do you call them? Like, I'm trying to think what the word I'm looking for. Kinesiology stuff, or not kinesiology, athletic training stuff that says this is the preferred recovery position. Yeah, it never felt good, right? I want the eyes up to see the play. If I'm gasping that bad that I need my arms up like that, I probably should not be on the field, Anthony. I'm just saying. I'm gasping that hard. I mean, it makes sense. I guess if I was cramping while I'm running, I'd probably put my hands behind my head. But I'd be curious if you did recovery, if it would help any better. I don't know. I've never tried that. I'll have to try that and try to get a cramp. Usually by the time I'm getting cramps, I'm starting to throw up anyway, which is never good. I don't know. I don't know the answer to that one. I'll have to look. But again, it hurts, right? But the idea of that is you're trying to stretch that cramp out. But what happens if we kind of rest and let the cramp kind of work itself out naturally? I wonder if that would release it quicker. Right? And cramps, obviously, we know that they could be problems with sodium potassium pumps. So maybe that we don't have enough sodium potassium in our body. We're not hydrated enough. So freedoms of movement, meaning which areas of the spine have the most movement. The lumbar region of our spine is our most injured area of our body, but it only has a moderate amount of movement. Why would you think it's the most injured part of our body?
Because every movement really stems from your back, and that has the least range of movement out of your whole back.
Yep, good. Right, and what else do you think leads to it? Weight bearing, bad body mechanics. There we go, right? Whether it's lifting, sitting, whatever it is. Our lumbar region is our most injured area. It will be the biggest patient that your clientele you're going to encounter in the field, right? You'll see patients coming in with lumbago or lumbalgia, both mean low back pain. That's an A, right? The other thing they might come in with is thoracalgia. I don't know why there's not a thorabago, I guess. I don't know why. In the thoracic region, we have very minimal range of motion because of the articulation of the ribs, right? So we don't end up with as many problems with that area and injuries to that area, but we end up with that area being very, very tight. Right? And it has to do with all the muscles and everything laying over it. In that area of your spine, obviously, we can usually find a couple trigger points, at least on most people in that thoracic region. Then our most freedom of movement area is the cervical region. That makes sense. We can do lots of stuff with our neck, right? Oh, no, you didn't. Okay, we can do lots of stuff with our neck. It allows for most freedom of movement up here, right? But it also is probably the second most injured area of the spine because a lot of times we'll get stuff like whiplash in that from it. And cervicalgia is pain in the neck, right? So what are some pathologies that can happen? Torticollis is a really common one. And torticollis can happen in babies, being congenital torticollis, meaning from birth, or in adults. And in adults, it's usually not called torticollis, it's usually called wry neck. Or at least on the East Coast, we call it that. And all that means is your neck's kind of stuck like this. So if I'm stuck like this, my right SCM is my problem. That means I need to stretch my right SCM by doing the opposite motions. Yeah, stiff neck is really what wry neck means. Yep. So when I'm twisted like this, in order to loosen up this SCM, I've got to rotate to the opposite side and laterally flex to the other side. Oh, that feels good because my right side is usually tight. So if you get a question about torticollis on either my tests or on the boards, perform the motion. If it says the patient has right SCM tightness, go, okay, so this is my right SCM, flex, rotate. How do you improve it? Well, I rotate to the opposite side, flex to the opposite side. Do the movement. I guarantee you're going to get caught on these. I actually just worked with one of the students on their boards about this morning, who she just wasn't getting torticollis. She goes, I know you covered it. I know it made sense when I was in class, but for some reason I keep getting hung up on these questions. And I'm like, do the movement. It helps with that. Cervical sprains and strains do happen, typically from whiplash and MVAs, motor vehicle accidents, right? And actually, you know, for if you're at all like a NASCAR fan like I am, that's actually how Dale Earnhardt actually died, was because of severe cervical trauma from hitting the wall, right? When he hit the wall at Daytona. And when that happened, why now, and maybe you don't know this, maybe you do, maybe some of you have watched NASCAR, why now do the people that hit the walls at high speed don't suffer as bad a cervical neck injury? Almost none of them suffer cervical neck injuries.
What is it, the Hans device or whatever?
Yes.
Didn't they have that before he died too?
And he refused to wear it.
Yeah.
Yeah, the Hans device, which is the head and neck restraint system, right? It's basically, yeah, it looks like a giant brace, Brooke, that goes around their shoulders the whole time. And it limits their rotation and limits their side flexion and flexion and extension, so that when they're going down the road, their head is kind of in a steady position. Now, the other side effect of that is they also have to then work their necks once they're out of the car, because their necks weaken a little bit while they're in there for 500 laps or whatever. But yeah, he also refused a closed-face helmet too, but that's beside the point, right? But yeah, so they're now going that. So the interesting thing is there's a new application for the Hans device. They're looking, can we develop a Hans device for football? A similar device for people that are high impact players, such as linebackers, running backs, wide receivers, that might protect their neck during high impact collisions. Interesting how those things kind of play over. Scoliosis and kyphosis, right? Scoliosis is a lateral bend of the spine. It's where the spine forms a snake. Kyphosis is an anterior posterior, right? Kyphosis and lordosis are anterior posterior deviations of the spine. Both of those can be congenital, or they could be structural, or they could be movement-based, meaning that they're positional, meaning maybe I sit like this constantly, so I develop a little bit of scoliotic curve in my spine because I sit like this constantly. If it's structural, there's not a lot we can do about it, unfortunately. Spinal stenosis is narrowing of that vertebral canal, right? A lot of times that happens from arthritis, where you start getting buildup on the inside of that spinal canal. And when that buildup happens, it starts compressing in on that spinal cord. And at that point, that's where they need to kind of go, well, maybe I need to do a laminectomy to open up some space here for the vertebrae, or for the spinal canal, to give some space. And then we have the herniated disc. And these are important to understand. So I put a good picture up here to make sure that you guys understand it. Disc herniation just means that the disc itself is moving. It could be this is usually osteoarthritis related, John. Osteoporosis is mainly going to be in the vertebral bodies. You're going to get holes in the vertebral bodies. So with the herniated disc, normal, the jelly's inside the donut, right? This is where we start getting disc degeneration, DDD. right? Now we get what's called a prolapse. And what a prolapse is we get like a little nipple popping out of our disc. So it's moved out either laterally, anteriorly, posteriorly. There's a little bit of it kind of coming out. The jelly is still inside the donut at that point. So with a prolapse, the jelly is still inside the donut. Physical therapy can still help if the disc is prolapsed, because at that point, the jelly is still inside the donut. When we start getting to extrusion and sequestration, now the jelly is starting to squirt outside the donut. Once we get out to this bad of a case, there's not much that physical therapy can do. We can try to alleviate symptoms, but a lot of times the disc at that point is really, really bad, and they might have to do a disc decompression surgery. Because you got to think about it, no matter where that disc moves, it's putting pressure on something in the spine, whether it's putting pressure on, the cervical, the actual canal, whether it's putting on the nerve roots, right? Or the posterior musculature. So anywhere that it moves, it's going to cause compression to occur. Again, typically doesn't move too anteriorly, but it can. It's possible.
So you said that you'd have to do like some sort of surgery that creates traction. Does it make it permanent, or?
Well, so once we get, so both you and John have the same question, similar questions, right? So for these two here, degeneration and prolapse, traction, good, right? Because traction can help suck that vertebral disc back to where it's supposed to be. We'll also talk about if I've got say a prolapse to my right side where it's pushing out my right side. If I do a lot of right side bending, I kind of squish it and force it back to the left and help kind of move that disc back naturally with the power of just the fluid moving, right? If we end up down here to this extrusion, or more importantly, the sequestration, they may go in and they may have to burn off part of that disc or cauterize it, or do an ablation surgery where they go in and they kind of burn it down. And then they may also put some support structures in there to keep it from moving further out. So they may do something like laminectomy or something like that, and then take that lamina and put them vertical to keep that disc in its place. And so they fuse vertebrae together. There's a couple different things that surgeons can do for that at that point. But the one thing to know is once we kind of end up here, that's very bad. So once we end up to extrusion and sequestration, we've got problems. At that point, the jelly has escaped the donut. Right? So if you take your donut and you squeeze it and the jelly shoots out of the donut, there's no putting that jelly back in the donut. That jelly's gone. Right? The only thing we can hope to do is save whatever part of the donut we have left. Does that make sense, Riley? Cool. And does that answer your question about traction, John?
Yeah, it does. Thank you.
Yeah, no problem. And again, it depends on what we do. If we do traction and pull it back, that's great. But if we also don't fix what's causing that disc to move, then it's just going to go right back, right? So if I'm a person that kind of leans like this constantly, and think about it. So if I lean over to my right constantly, what direction are my discs going to try to shift?
Side.
Yeah, to the other side, right? Contralaterally. Because if I'm here, I'm opening up that side of my vertebrae. So my discs are going to try to shoot the other way. It's just a natural occurrence of having fluid-filled discs back there, right? So I'm constantly leaning like this. Maybe I've got a short leg. Maybe I've just got a scoliotic curve, whatever it may be. Those discs kind of go this way. If I don't correct my posture, I can put me on traction, make me feel great walking out of the clinic, and then 6 hours later when I'm back to this again, I cause my pain again. So we've got to not only do the traction component, but we also got to fix the problems, right? That's why they don't just get modalities when they come to see us.
Would the pain be, since it will go out contralaterally, would the pain be on, like if you're leaning to your right, would the pain be on the left side? Right?
Usually,
Okay.
usually, but also I could get a little bit of pain over here, couldn't I? Because of the compression of that side.
Yeah.
Right. So typically it's going to be on the side that it kind of shoots out to. So I'll get some pain. Like if I had my, say, L4 was my disc is sliding out. You can't see I'm down here below my belly button. If my L4 is my problem, typically I'm going to get L4 symptoms down that left side because that side of the nerve is being compressed, right? But I may also get some right side issues. And what's funny is usually what happens when we start fixing and start getting me this way, then we start getting a little bit of right issues because the right's like, hey, you kind of compressed me this whole time. Now I've got more space. So that's where we tell them, it's probably, when we work on low backs, we tell them specifically, it's going to get worse before it gets better, right? Because we got to get them back to getting everything back to the spine and make it more painful, and then it'll start relieving itself. That makes sense?
Thank you.
Yeah.
Yeah, it does.
So then we have our osteoporosis, which we talked about, where that low bone density results in vulnerability of the structures of the vertebrae themselves. We can end up with compression fractures because of osteoporosis, where something as simple as sitting down in a chair can cause those bones to bang together and fracture. I actually had one, I think I told you guys about this, where a lady sat down, and when she sat down, she fractured L3, L4, L5, just sitting down. Right? And she's like, I didn't know. I just, all of a sudden I had massive back pain and I couldn't move my legs. I didn't know what happened. Well, she had a really bad osteoporosis. And so then when she sat down, everything just kind of snapped. And she's like, I didn't even think about it. I was out in the garden. I had been working all day long. And I came in and I just kind of flopped in my chair like I normally do any other day. And sure enough, snap goes the discs. Or that snap goes the vertebrae, more importantly. Then we had this spondylitis, spondylolisthesis, all those fun spondylolas, right? And pars interarticularis, which is where things kind of get stuck in the articular region. A spondylysis, lysis meaning destruction, right? Typically happens back here in the posterior aspect of the spine, where we get a crack forming. So when I think lysis, I start thinking crack. A spondylolisthesis is where now we've had that crack for a little while, right? So spondylysis can quickly go to this, where that crack formed, and now the bone falls off. And now listhesis, meaning I've got a bony break that's kind of floating back there in my spine. They've got to go in and do surgery for that. There's really no way that's going to heal effectively. And you also have this term called spondylitis, which all that means is spondula, spine, articulation, inflammation. So it's inflammation of where the spines articulate with one another. Those terms are probably the hardest terms for your boards because you're like, oh God, what's going on here? I don't remember which is which. And I just realized I used that picture and covered up part of my surgeries, but oh well. So lysis is the start of the form of the crack. Listhesis is where that crack has snapped off. And litis is just inflammation. That was the way I remembered them for my board. So lysis, again, lysis meaning destruction, is the crack forming. Lithesis, to get my break. And then litis is just inflammation. Now, let me ask you a quick question. Could spondylitis, inflammation of those kind of articular surfaces of the spine, eventually lead to spondylysis and spondylolisthesis? Like spondylolisthesis? Yes.
Yes.
Absolutely. Yeah. Right. And that's kind of that's one of the common progressions. You start with a little bit of inflammation, then you get a crack, then you get a snap, and then you're in for surgery. Yay. I put a video for both the anterior and posterior cervical decompression surgeries. And when you hear decompression, right, that means they're relieving pressure on the nerves, whether it's the actual spinal canal itself or whether it's those nerve roots that are coming out, what we call the nerve windows, where those nerves are exiting the spine and kind of going out to the periphery. Those are called the nerve windows. And the next question I usually get is, okay, Mr. McKeever, which of these is the better of the two surgeries? Should I get an anterior or should I get a posterior? Well, I'm going to say, talk to your surgeon. I don't make that decision. What I will say is I've seen more people come out better off from an anterior decompression surgery than a posterior decompression surgery. I don't know why. I'm guessing because of the anterior longitudinal ligament. And when you go in through the posterior, you got to cut more ligaments to get in there. But it, again, is going to depend upon what your surgeon does. And these will relieve pressure. They can also be helped to kind of alleviate some of the pressure on the disc. The other thing I don't have on here, right, is where they go in and they burn off part of the nerve, right? That's called ablation or ablasive surgery. And have any of you seen on television the ad for Laser Spine Center? Where it's like, 2-hour surgery and you're up and walking in the same day. And it relieved my back pain. Right? You've seen it? Sounds good, right? Like, I don't have to have total back fusion surgery, or I don't have to have a decompression surgery, and I'm up in an hour and a half, and man, I'm walking the same day, and my pain's gone. Sounds pretty good. Why is the pain gone?
Because the nerve is burned off.
Yeah, the nerve's dead. You basically burnt the nerve off. Now, we've also learned that nerve can regrow and can regenerate. So guess what can happen 5 or 10 years down the line? It can come back. Yeah, Brooke, right? It can come back. And then you're back in for more surgery. Right? So I'm not going to say that ablation is a bad way to go about it. I'm never going to say that, because here's the deal. If you've got a patient that's in extreme pain because of, sciatica or something to that effect, any relief they get is going to be better relief than what they're at, right? And maybe the problem decompression surgery is just not a thing for them. It's not going to work. It's not going to help them. The problem is their nerves are just that inflamed that they're taking up extra space. Well, maybe going in and burning off the sensory component of the nerve is the way to go. Right? And that will relieve their pain. And here's the deal. If we can get this ablation to happen, we can get the pain relieved, and we can get them more active to stop what it started in the first place. Is that necessarily a bad thing? I don't know. Probably not. Right? Because as soon as you start having that low back pain, you start doing less. So I'm not saying Laser Spine Center is bad. That is not my thing. So if Laser Spine Center watches this video and yells at me, I am not saying that. I'm also not advertising for them. But at the same time, I have my concerns about necessarily going in and burning off nerves, especially when maybe we didn't need it. So there's a big picture of that. Goniometry and manual muscle testing. Open versus closed pack positions of the spine. And this is the whole spine. Open pack position is midway between flexion and extension. So that's kind of neutral, right? You're a little bit neutral, maybe a little bit flexed. That's the open pack position. Closed pack is full extension, right? That makes sense. If I'm in full extension, you're not going to be able to move any of my vertebrae at all. When it comes to mobilizations of the spine, PTAs say what? No, good, right? I would love to observe you, Mr. and Mrs. PT, perform mobilization of the spine, but that is out of my scope of practice. There are capsular patterns of the spine which may lead to doing mobilizations of the spine, right? And if you ask a chiropractor, all of the pain that you get in the spine is a capsular pattern. I don't totally agree with that, but they are crack dealers. So, I mean, that's their job, is they crack backs. I got it. See, I got some laughs going on there, right? They are crack dealers, aren't they? Crack. Anyway, So in the cervical spine, you have equal limits of all motion except flexion. So it's capsular if I've lost extension, rotation, and lateral bending. But if usually I have normal flexion, right? That's a capsular pattern. In the thoracic region, it's greater limits in extension and lateral flexion than a forward flexion. So if you notice, a lot of the, if it's a forward, if they're limiting forward flexion, it's not capsular, it's probably muscular, right? The rest of it's probably a capsular pattern. And that makes sense because of all those dang ligaments all over the spine. And then we're just chasing, I don't know which ligament is it that's too tight. Let's just try mobilizing the whole way up and see if it gets better. Lumbar spine they really didn't have much on it, but from what I've seen of the lumbar spine, it's very similar, is that it's limits in extension, not in flexion. But again, one of the main movements we're going to have patients do if they have a lumbar spine problem, extension activities. It's kind of the goal. Full range of motion, flexion of the neck, it's about 50 degrees, extension or hyperextension is about 60. Rotation, you should have 80 to either side. And then lateral flexion about 45. I just popped my neck, I'm gonna have a stroke. Thoracolumbar, so thorac lumbar, right? Flexion about 60, extension about 20 to 30. Lateral flexion 35, and then rotation about 45. So your neck is gonna have more rotation than your body, and that makes sense, right? I can turn my neck pretty far, well, not as far as I used to, but it's not like I can turn, when I do the twist, I don't get a lot of motion going on there, right? It's not like I have a ton of rotation. Functional range of motion in the cervical region, normally 40 to 50 degrees of extension is the major thing. I don't know why we're looking at the ceiling, but that was one of the functional ranges of motion the book had you look at. The main one is for driving, and that is cervical rotation. You should have about almost normal range of motion to clear your blind spot. Why is that? Well, because where does most of our accidents occur? From hitting people in our blind spots. Now, there are all kinds of things that are helping that nowadays, aren't there? Right? I don't know how many of you guys have blind spot monitoring on your vehicles that actually warn you when you get somebody in your blind spot. I find those really annoying. I was driving when I was in Virginia. The Camry that I rented had a blind spot camera that every time something was in my blind spot, the camera kept showing that car that was my blind spot. And that drove me absolutely insane. I'm like, I want my radio back. I want my MTV. But it's not a bad thing for somebody like me that's limited in my rotation to have a blind spot monitor, especially driving the big honking truck that I drive. But Jason's right, they are kind of annoying, especially when they're the beeping kind, right? Beep, 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 beep. But that's a sign. It's not a car. But the other problem we have is, as cars have gotten more and more safe, right? We have the A pillar that's in front of us, that B pillar that sits right behind us where our seatbelt is, that B pillar keeps getting a little bit thicker because a lot of your side curtain airbags are kind of stored in that region, right? So when that B pillar gets thicker, it creates a bigger blind spot. We have a blind spot at the A pillar, and we have a blind spot back here at the B pillar in our vehicles. And so I understand why they're trying to make things safer for us, but like Jason said, they are kind of annoying. All right, so manual muscle testing of the cervical and thoracolumbar region. Here is the good news. You are not going to be tested on these for your comps. I would suggest looking at them before you go on your clinicals, right? But, and we're going to perform them. We're actually going to practice goniometry of the cervical region and the trunk, just so that you understand it. But manual muscle testing pretty much makes sense. I'm just going to, just as an example, if I'm going to test flexion, I'm going to come forward, I'm going to push back. Don't let me push you backwards. We are not going to put as much force on their necks. Right. MMT is myotone testing. It absolutely would be. Yeah. Cervical MMT is just pretty much myotone testing. It is. But also, we're not going to put as much force, right? Because neck, not as strong maybe as biceps or quads, right? I guarantee you test somebody's cervical rotation, like, okay, don't let me push you that way. And you're like, "Quack." They're not going to like you very much, right? It's just a little bit of pressure. See if they can rotate. Okay, good, good. Can you flex? Good. Can you extend? Good, right? Can you laterally flex? Can you laterally flex? We're not doing a ton of force there. And I'm going to be 100% honest, in the thoracolumbar region, I don't know when I've tested this. I know that I've put them on like a sheet for an eval for a patient, or not an eval, but a sheet for the PT to eval. But I really rarely do manual muscle testing of the lumbar region. It's more the PT that does it, just because I don't know, like I'd rather do functional testing where I can see if they can sit up or if they can roll out of bed and stuff like that. Then, all right, I want you to do a partial sit up and now don't let me push you back, or something to that effect. When we get into goniometry in the class about these, I'm going to show you the way the book does it, and I'm going to show you my way of doing cervical goniometry, because I think my way is a little bit easier than the book does. The book has very kind of specific techniques for it, and the way I do it is the way most clinics do it. And we just use a regular old goniometer. We don't use bubble gonies, which we will show you how to use the bubble gonies. But again, this is not something you have to worry about being on a comp or anything like that for you. And when I say comp, the comp this semester is not going to be a real comp. It's not like I'm drawing you apart individually. I'll talk about that right before we go back to full-time in the clinic. All right, folks, that is it. I made it, you made it, we made it. Any questions about the cervical or neck? Yes.
Oh, not about cervical, but I was thinking, should have lost my train of thought. I was thinking, are we gonna go over the final like tomorrow, like how we did for the midterms? Because I know Monday we don't have any class, and then your final is that Wednesday.
What opens up? I'm gonna go over it before I open it up. Yes, if that's what you're asking.
Okay.
I am. Yes. To answer your question, yes.
So tomorrow.
When did I say I was open? Did I say I was opening it up on next Wednesday?
You have it open on the 7th.
So my brain doesn't always. I don't want to go to announcements. I want to go there. Thank you. Yeah, I mean, I could.
I just want to see if I need to study this weekend.
You don't have to study this weekend. No, we'll review. Actually, probably what we'll review, because again, I'm going to open it up and it's going to be a week. I may actually not even open it till Thursday, honestly, till we've gone over everything. You're going to have a full week to do it. So actually, I'm going to probably say we're going to review next Thursday for it. So don't study this weekend.
That's
don't
perfect.
Don't freak out.
Okay, perfect.
Enjoy your weekend. Stop recording.